So if an endoscopist is doing screening in an average risk mixed population, they should be finding at least one adenoma in 25%, or about 1 out of every 4 patients that they scope. 1 out of every 4. Now, what we have found through a number of different studies is the ability of endoscopists to find those adenomas varies tremendously. And endoscopists who are working in the same settings, at times you'll see some who are finding adenomas in only 10 or 12% of their patients. And then you'll find others in those same environments who are finding them in 45% of patients. So wide variation. Why the variation isn't entirely clear. It is clear that some people are just much better at doing it, at spotting those adenomas. And we don't know why some people don't do as well. But we also know that if you work with those people who are low performers, the ones who are only finding adenomas in 10 or 12% of patients, if you work with them and help them over time, you can boost them toward that 25% target. You're never going to get them up to 40%, but you can help them move forward. But first, in order to do that, you've got to know who the good performers are and who the bad performers are. Again, are these numbers important though? Do they really matter? Well, this study at Kaiser looked at adenoma detection rates, and they have a closed system. Kaiser of Northern California, it has a colorectal cancer screening program that spans more than 30 years. They started off with flexible sigmoidoscopy. Then they began doing a lot of colonoscopies in the 80s, 90s, and early 2000s. And then over the last few years, they've also added in a stool testing component. But they do a lot of screening colonoscopy. So they also have a very effective and complete electronic medical record. So they look back over colonoscopies performed in their system between 1998 and 2010. Now, these colonoscopies are being performed by a group of endoscopists who all work in the same environment. They're all seeing the same kinds of patients, and consequently, you would expect that their numbers would be fairly similar. What they found was they had endoscopists finding adenomas in as few as 7.5% of patients, and as high as 50% or more of patients. And their average was somewhere in the 30% range. So they were, on average, achieving that target, but there were a lot of folks who were performing at a much lower level. But then they took the next step and said, well, does it really matter? So they looked at the outcomes in the patients who were treated by these different clinicians. They looked at interval cancers. Now, as I mentioned earlier, if a colonoscopy is read as normal, that patient doesn't need to be screened again for 10 years. So that 10 years between normal colonoscopy and next scheduled colonoscopy is the interval. Cancers that develop during that 10-year period are cancers that would be missed because nobody's going to take a look for the next 10 years. So they looked at how many patients who were treated by these endoscopists developed a cancer in that 10-year period before the next colonoscopy was due. And what they found was those endoscopists who had the lowest adenoma detection rates, who were finding adenoma in the fewest number of patients, those patients were more than twice as likely to develop a cancer during that 10-year interval. More than twice as likely to develop cancer. And they looked at the likelihood of a fatal cancer and found that patients who were treated by those docs who had the lowest adenoma detection rate were 3 times as likely to die from colorectal cancer. So the adenoma detection rate matters. There have been a number of other studies that have looked at this and found the same thing. The likelihood of being diagnosed with or dying from colorectal cancer is much higher if you're treated by an endoscopist who doesn't find a lot of adenomas. So the adenoma detection rate is real. Now, what do you all as primary care docs do? Well, you're not doing the scopes in most cases. If you are, there are a number of primary care endoscopists here in the state, I understand. I'm not going to call you out now since I just talked about these quality measures who may or may not be tracking them. But if you are an endoscopist, primary care, surgeon, GI, one, you need to be tracking your adenoma detection rate and the other quality features that I talked about. If you are a primary care doc and you're referring patients out for endoscopy, if you have a choice, you want to refer to endoscopists who are tracking these numbers. Now, I know in many environments, you don't have a choice. You just have to send your patients, because there may only be 1 or 2 endoscopists in the area who are willing to see your patients. But at least asking your endoscopist, are you tracking these quality measures? Do you know what your adenoma detection rate is? They've heard of it. They know that their societies are encouraging them to do it. But in many instances, they're not doing it. But some prompting from you all in the primary care community, and particularly if there is an element of potential competition. If you have a choice between sending your patient to an endoscopist who says, yeah, my adenoma detection rate last year was 28%, versus one who says, adenoma detection rate, what's that? Oh, no, I'm not bothered with that. I know I'm doing a good job. Well, you can decide where to go. But in general, we want to try to send our patients where we know they're going to get quality care. And this turns out to be a really important quality measure. Okay, so, oh man, I'm not done bashing colonoscopy yet. Okay, let me say right now, I am not saying colonoscopy is a bad tool. Colonoscopy is actually a very good tool. And I will confess, when I turned 50 and it was time to get screened for colorectal cancer, I chose to have colonoscopy. I didn't choose it because I viewed it as a strikingly better tool. I chose it because I'm lazy. And I knew that I was not going to collect a stool specimen every year and send that back. And colonoscopy, if it was normal, was going to be once and done for 10 years. So that's why I chose it. But it is a very good tool. But it is not a perfect tool. And again, you and your patient should understand it. The colonoscopy requires a lot more of patients, frankly, than collecting a stool specimen because of the prep and as one element. And, you know, I'm a relatively healthy person, and the prep wasn't dangerous to me, but it was sure no fun. It was one of the least fun evenings I've ever had. But for patients who have other health issues, for patients who may have mobility problems, trouble getting back and forth to the bathroom, for patients who have brittle diabetes and their diabetes is difficult to control, and now you're going to have them not eat anything to clear liquids, etc. I mean, it can be problematic. It can be challenging, especially for some of your older patients. In addition, colonoscopy requires, and at least every center I'm familiar with, requires that the patient have someone bring them to that facility and stay there and then take them home. And that's largely for medical reasons, medical reasons, which are going to be, in most instances, sedating individuals. But that puts a real burden on the patient, not just on the patient, but the patient and whoever they get to bring them along. Colonoscopies are usually, in most environments, done, in pretty much a 8 to 5 kind of day. So you have patients who are working in environments where they don't have paid time off. Well, now you're asking them to lose a day's salary to go get that test done. So there are a number of burdens that are associated with colonoscopy. And then in this part of the country, you may be talking about a 2 or 3 hour drive to get to the nearest endoscopist. So you are really potentially imposing some burdens. And it's important to keep that in mind when you're talking to patients about their screening options. Access, we've already talked about the impact of insurance and geography. But another factor that is oftentimes overlooked, but turns out to be really, really important, is the patient preference issue. And I'll go into a little detail about patient preference, not here yet. Let me switch gears now. So we've talked about colonoscopy, the good and the not so good. Now let's talk about stool testing. Now there are 3 different broad categories of stool testing. There's 2 broad categories and then 1 subcategory. There is a stool test that looks at abnormal DNA. They actually are able to, as stool is passing through the colon, it scrapes a few cells off the colon wall. They can now go in, find those colon cells, break those cells down, and look at the DNA in those cells, and look for mutations of DNA that are associated with cancer and with polyps. It's pretty cool technology, actually. So they look for DNA mutations. And the one test that is on the market is called Cologuard, and that test actually combines a test that looks for abnormal DNA with another test that looks for evidence of blood in the stool. And that test is approved by the FDA to be marketed as a colorectal cancer screening test. It also is paid for by Medicare. So it is an option for your patients who have Medicare. Very few private insurers are paying for it, and it is very expensive. Medicare reimburses it at $500 per test. So in the commercial market, it's likely higher than that. But for patients who have Medicare, they can get this test usually with no associated copay. It has to be repeated every 3 years based on the manufacturer's recommendation, 50s and 60s. So it is achievable, even in the FQHC environment, to get to those 50 and 60% rates, but you gotta put in the time, energy, and effort, and we're gonna talk about how you can help move that. So the overall average for federally qualified health centers across the 2 states is 32.3%. And then this is data that comes, I believe, from GIPRA, from a different data source as opposed to the BRFSS. And as you can see, this estimate is significantly lower for the American Indian population. And frankly, this is more in line with a lot of the other data that we see. But again, very explainable in the fact that we've got patients who've got very significant barriers to getting screened. We're going to talk about how to overcome or work around some of those barriers as we go through today. Now, it is important to recognize, however, that while certainly not having insurance puts you at greater risk of not being screened, that having insurance is not a guarantee of being screened. This is 2012 data from the Centers for Disease Control, and they looked at people who had never been screened. At that time, about 65% of the population was up to date, and another 7% had been screened in the past, but 28% had never been screened, these are 50 and older. Then when they looked more closely, they found that about a quarter of those folks were uninsured, but 3 out of 4 people who had never been screened actually had health insurance. So simply giving people insurance does not assure that they're going to get screened. There have to be some other pieces put in play for them, which we'll talk in great detail about what some of those pieces are. So, who should be screened? This shows that colorectal cancer, the likelihood of developing colorectal cancer goes up as we age, and it continues to go up. But there's a pretty sharp uptick here around 50 or so. And for this reason, every major organization recommends that screening for average risk populations begin at age 50. And how often you're screened will then depend on which test is used. But every group recommends average risk screening at age 50. Now the definition of average risk varies a little bit between groups. And there are some organizations that actually, because of higher rates among Native American populations, recommend screening begin at 45 for American Indian and Native American populations. That is not universally accepted. Frankly, it's not in the current ACS guidelines. That same recommendation is made by other organizations for African Americans because, again, higher likelihood of developing colorectal cancer and somewhat earlier onset. So there are a couple of groups that recommend screening beginning at 45. But in general, average risk screening begins at 50. Now, it's important to recognize other groups that we know to be at strikingly higher risk, and for that reason, there are different screening recommendations. So these include people who have a personal history of adenomatous polyps, the kinds of polyps that can advance and turn into cancer. A personal history of colorectal cancer. If you've had it in the past, your chance of getting it again is much, much higher. A personal history of inflammatory bowel disease, Crohn's disease, or ulcerative colitis. Once you've had that for 7 or 8 years, your risk of colorectal cancer goes up tremendously and continues to rise through the remainder of your life. Family history is the other key risk factor. And unfortunately, family history is one of those things that oftentimes does not get collected in a way that makes it useful. In many environments, people, you have a family history checklist. Do you have any family history of cancer? Check, yes, I have a family history of cancer. What do you do with that information? Is that actionable? Is there anything that you as a clinician can do based on that? No. You need to get into the details. Is there a family history of colorectal cancer? If, your second cousin twice removed had colorectal cancer when they were 75, that probably has no impact on your risk. On the other hand, if your mom, dad, sister, brother was diagnosed with colorectal cancer at age 55, you need to start screening at a significantly earlier age. In general, about 10 years before the age of onset of that case. So if the patient's mom was diagnosed with colorectal cancer at 55, that person needs to start screening at 45, let's say. Did we have, Shannon, I don't know where you are, do we have that same handout that we had yesterday that included all of the risk factors and increased risk guidelines? If not, we'll try to get it for you. But there are separate guidelines for colorectal cancer screening for individuals who have these risk factors. And people who have these risk factors, colonoscopy is the only recommended screening test. So it's important that you identify these folks, and we'll talk a little bit about how to do that. But when we talk about the average risk population, that's basically 8 out of 10 of the patients who you see in your office every day. And for average risk patients, there are a variety of different tests that are recommended. These are the ACS guidelines that were last updated in 2008. We're in the process now of looking at all the evidence related to colorectal screening and updating these guidelines. When we went into this guidelines process, we went in with the idea of slimming down the list because we had heard from clinicians and patients, there's too many tests, we don't understand, it's confusing. So we went in hoping that we would narrow the list. We actually ended up expanding the list at that time because there were more tests that had come into the marketplace that had evidence supporting their value as screening tests. The U.S. Preventive Services Task Force around that same time actually did an evidence review, and they stuck largely to the tests that they had recommended in the past. They did include with some very stark limitations a couple of tests that are also included by ACS. But you notice that these tests, colonoscopy and high sensitivity stool testing and DART, these are grayed out. FLEX-SIG, CT colonoscopy, stool DNA test. Are they gray because they don't work? No, there's good evidence for them. But their use is very, very limited in the U.S. for a variety of reasons. Consequently, probably 98% of screening in the U.S. occurs using one of these two tests. So we're going to focus on those tests. I will touch on one or two of the others as we go through them. So colonoscopy. Anybody here not know what a colonoscopy is? No. When I first started doing this job about 15 years ago, actually there were a lot of patients who didn't really know what a colonoscopy was. That's changed dramatically. And most clinicians have understood for a long time. Colonoscopy, long lighted tube with a camera on the end, looks at the entire length of the colon. So one of the real benefits of colonoscopy is you see everything from the anus all the way to the cecum, if it is done well. Colonoscopy has the advantage of not only being a screening test, but if something abnormal is found, you can take a piece of it and send it off to the lab and get a diagnosis. It also has the advantage of being therapeutic because if a polyp is found during the course of a colonoscopy, in the vast majority of cases, that polyp can be removed during that same screening exam. So it's screening, diagnostic, and therapeutic. It has the additional advantage if the exam is completely normal, if no abnormalities are found during that exam, it only needs to be repeated every 10 years, provided it's a high-quality exam. So, screening, diagnostic, therapeutic, only once every 10 years, it's a really good test. What's not to like? Well, unfortunately, there are some. Now, because of those features, it has become by far the most common screening test used in the U.S. and probably accounts for probably 85% or more of the screening that takes place. But it is often referred to as the gold standard, and that kind of makes me grit my teeth a little bit when I hear it, because gold standard implies a level of perfection that frankly colonoscopy is not achieved. Colonoscopy is a very good test, but it's been shown in a number of studies that colonoscopy will miss about 10% of significant abnormalities. So if I do a colonoscopy on a patient, report my findings, walk out of the room, another endoscopist comes in, does a colonoscopy on that same patient, they're going to see 10% of things I missed. I'm going to see 10% of things they missed. And those are usually large polyps that can transform into cancer, but some cancers are missed in those studies as well. And realize those are studies that are being done in academic centers with very experienced endoscopists who know that someone is coming behind them to check over their work, and they still miss 10% of lesions. Some of that has to do with the quality of the exam. We'll talk a lot about that coming up here shortly. But it's important to realize for both you and for your patients that a colonoscopy is not a perfect exam. Now, where this becomes really important is in those patients who have a colonoscopy that's reported as normal, and then 3, 4, 5 years later, that patient starts to have bleeding from their rectum, or they begin to have changes in their bowel habits. And the clinician looks at their chart, oh, you had a normal colonoscopy 4 years ago, so can't be that, let's ignore that. That's how people get cancers missed. And I hear that story over and over again from colorectal cancer survivors. They were told, oh, well, your colonoscopy was fine 4 or 5 years ago, so we don't need to worry about it. And they go on with symptoms for another year, and then finally they get the exam and find that they've got an advanced cancer. Realize that screening guidelines have nothing to do with a diagnostic assessment. So if a patient shows up with new symptoms, even if they've had a, quote, normal colonoscopy in the end, realize that that colonoscopy was not perfect and something may have been missed. So if they've got new symptoms, you treat them just as they would if they've never had a procedure. So if a colonoscopy would be indicated because of their symptoms, then you need to send them to an endoscopist. Colonoscopy also is significantly more costly on a one-time basis. Now, a program of screening with colonoscopy compared to a program of screening over time with stool testing or other kinds of approaches is actually cost-effective. So colonoscopy is a cost-effective approach to colorectal screening. But for individuals who don't have insurance, or in the case of many of you all, for individuals who may live 200 miles from an endoscopist, the cost associated with getting a colonoscopy may be very high for them. So it's important to keep that in mind. Colonoscopy also, while it is overall a very safe test, it has a much higher potential for patient injury than any of the other screening tests that we're talking about. While colonoscopy is safe overall, it is estimated that somewhere between 1 in 500 to 1 in 1,000 individuals who are undergoing a screening colonoscopy will experience some complication that is significant enough to require additional medical care. Now, in many instances, that means they have a little bleeding and they show up in the emergency room. Sometimes, a lot of bleeding, they need transfusions. Sometimes a perforation, a hole can be poked into the colon. That's actually much more common if there is a polyp removed during the procedure. And keep in mind, we're talking about doing the screening exam in people in their 60s and 70s. Some of those folks have other underlying diseases, so strokes, heart attacks, not uncommon after a screening colonoscopy. So you and your patients need to keep that in mind when you're making referrals. If this test, while it is safe overall, there are some potential complications. But one of the main things that many clinicians and the vast majority of patients don't appreciate is there is tremendous variation in the quality of colonoscopy as currently practiced in the U.S. And over the last 10 years or so, as we've studied this quality issue more and more, we have found some pretty startling things. There are a number of different key indicators, and these are very important quality factors that frankly should be addressed in every colonoscopy and mentioned in every colonoscopy report. But unfortunately, they often are not. The quality of the prep makes a big difference. The colon is not a clean organ. So if you have someone who comes for colonoscopy and either they took their prep but it didn't do a good job, you've got a lot of stool and mucus in the colon, the endoscopist simply can't get a good look at that colon wall, and therefore polyps and even cancers can easily be overlooked. The cecal intubation rate, that is, reaching all the way to the cecal, is another important factor because cancer can occur anywhere along that spectrum. A endoscopist who practices good, high-quality colonoscopy is going to reach the cecum in about 95% of cases. There are some cases where it's just not possible, but your endoscopist should be reaching the cecum certainly more than 9 out of 10 times. And then the other quality factor that really has turned out to be probably the most important of what we're able to measure right now is what's called the adenoma detection rate. How many of you all are familiar with the adenoma detection rate, or the ADR? Not surprising, the vast majority of primary care folks don't know anything about this. It is something that endoscopists are now becoming more aware of because every major GI endoscopy society has these sort of quality indicators and is encouraging their members to begin tracking and measuring these. But unfortunately, all they're doing is encouraging. There's usually no teeth in that. There is no enforcement. There's no requirement to do so in many systems. And consequently, even though these are known to be very important factors, in many endoscopy environments, no one's looking at this information. Now, the question is that important? Are these just some other numbers? I mean, we already have a multitude of numbers and all sorts of things that we as clinicians are being measured and tracking. Does it really matter? Well, with the adenoma detection rate, it really does. The adenoma detection rate is the proportion of patients in whom an endoscopist finds an adenoma. And these numbers are a lot higher than many of us realized. Again, over the last 10 years or so, we've come to recognize that an endoscopist should be finding at least one adenoma. And this is significant. These aren't little pimples. We're not talking about little 1 and 2 millimeter lesions. We're talking about adenomas that have the potential to advance to cancer. One of those should be found in 30% of men and 20%